Dr. VIPUL ARORA, who's a senior consultant in Vedanta Netralaya, Ghaziabad, and he has another situation to show us. On to you, Dr. VIPUL.
Good evening, everybody. Ma'am, I'm in Roorkee, Uttarakhand.
Oh, sorry.
Yeah.
So sorry.
Yeah, this case was referred to us for IL exchange, and the cataract surgery was done 1 week back. The IL implanted in this case was 18 diopters, whereas the intended IL to be placed was 23 diopters. So I am doing the IL exchange in this case. After putting a HPMC, main incision is extended slightly internally more rather than externally, and using a dispersive viscoelastic to coat the endothelium. Because the main role in IL exchange is to safeguard the vitreous as well as the PC as well as the endothelium. With the help of dialer, the IL is manipulated, and since surgery was done 1 week back, so it was not difficult to bring haptic into the anterior chamber. So I'm using a dumbbell dialer now to protect the posterior capsule and bringing slowly and gently into the anterior chamber above the iris, over the iris plane. And similarly, the second haptic. Now, under this IOL, the indented IOL of 23 diopters is implanted in the bag, taking care of protecting the endothelium. And viscoelastic is injected time and again, taking care not to overfill the chamber, but at the same time to protect the endothelium. Now, after this, the IOL is held with this IOL holding forceps. And thanks to Dr. Chitra ma'am for this initiative of this ARC, where I saw one of the doctor using this forceps. And so I bought one for myself. So this was really handy in case of IOL exchange. And with this, I'm using the Park Chang IOL cutter on an MST handle. And since the scissors are sharp enough and the IOL cuts in one go. Here I would like to mention this forceps actually hold the IOL very firmly. So after the IOL is cut, we have to use the second instrument to disengage this forceps from the optic of IOL. And after this, I'm using this forceps again to bring the two halves outside slowly and gradually, holding it from a little in the middle part of the optic, injecting viscoelastic again. And similarly, the second half is withdrawn. Here the incision is not more than 2.8. And the IOL explanted is checked for its completeness. And AC wash is given and wound is hydrated. And next day, the patient had 6/9 vision in this case. Thank you so much.
Thank you. That was again a very gracefully done surgery. Really nice. You showed very beautifully. It was shown how to use the right instrumentation. But just for the sake of discussion, in these early cases where the haptic is not fused to the capsule and all that, I would have also done your way, but I just wonder, does any of you would like to get the haptic out, one haptic out of the incision and then go on to cut, or would you all do it exactly the way he's done? Any of you on the
I
expert?
would do the same way as he did, because when I get the one haptic out, the part of the optic also comes very close to the incision. So it tends to crowd there and it tends to touch on the endothelium. Very difficult for me. But I would do, this is a perfect, fantastically shown and very gracefully, elegantly shown. Congratulations. Only thing is, I want to know, where did you buy that forceps?
From Epsilon.
Epsilon. Very good. Thank you.
Both,
And only thing is, one more point is that.
Both the forceps and the scissor?
No, other one, scissor cutter.
No, yes, both from Epsilon. And I would like to thank again Chitra ma'am, because I have seen this case, some other surgeon doing it on ARC platform itself.
Yeah.
And one more point is to inject viscoelastic, because it is fresh, it is fine. But viscoelastic into the bag also will be a good idea.
Yeah, actually it's an edited video.
The bag before
it's a edited video, but it was I have
just to mention that for a long term.
Would anyone use a Sulcoflex piggyback in such situations, or all of you would go ahead and?
I think
if it was a year, it was sometime later.
If it is an old case, you can think of placing a Sulcoflex piggyback IOL, which is a very good option. But in a fresh case as this, I think all of us would consider doing an IOL exchange only.
I recently used this piggyback in one of the cases of RK incision and 6-year-old IOL case done. And the IOL I used was of IOCare. So they customized it for me, and it was not at all pricey. It was
actually Sulcoflex is very costly also.
Can I ask one doubt?
Sulcoflex is Rainer. Yes,
Dr. Sandhya.
In case of this looped haptics that won't come out so easily like this, in such cases, how do you remove it? You cut the optic and remove the optic alone, leave the haptic in the back, or you just cut the looped haptic also and then take it out?
1 week, all IOLs will come out.
Yeah.
1 week,
not 1
1
week.
month.
Because it's slightly longer duration, then this looped won't come out so easily.
Then you leave the haptic, cut the haptic, leave it
Cut
in
the haptic and just take out the optic.
Can I add something? This cutting of the IOL is a very nice technique, but recently I've shifted to twist and out technique, especially for single piece, where you hold the IOL through main piece, main port, and support the endothelium with the spatula and twist your hand. IOL gets rotated and then it comes out through 2.8. You don't need to juggle and cut it.
A hydrophilic lens or a hydrophobic lens?
Hydrophobics are very easy, since hydrophilic are thicker than hydrophobic. It's bit difficult to come out through the same incision.
I have also seen this, but it seems a little scary to just do it, and endothelium injury might be a possibility.
Yeah, initially, but once you get on with it, it's a very easy technique rather than cutting. And I've done almost 7 to 8 cases, and it has popularized by Dr. If I remember his name correctly, Dr.
Uday.
Yeah, he popularized it, but somebody else has, his name is Dr. Pant, it seems, if I correct it rightly. So you need a practice, definitely, but it's once you get a hang of it, it's definitely easier than cutting the IOL.
Thank you.